Hey everybody, welcome back to Pathology. Today we're going to go into Hodgkins versus non-Hodgkins lymphoma. So starting off with the mantle cell lymphoma, this is a type of non-Hodgkins lymphoma. So not necessarily a good cancer because non-Hodgkins is very hard to treat. It doesn't metastasize in a linear or like a standard way. Hodgkin's lymphoma does. So mantle cell lymphoma is found more in older, middle-aged European males, so patients in their 40s, or not, sorry, 50s, 60s. And the tumor cells are going to resemble the Mantle Zone B lymphocytes, and the nuclei are going to be irregular or cleaved. The lymph nodes are going to become undifferentiated with few reactive germinal centers, and all of them are going to be surrounded by the tumor cells. This is going to be associated with the translocation 11 and 14, and that's where the loci of IgH and cyclin D1 is switched, and then there's an overexpression of cyclin D1, which causes the cell cycle to progress even past the G1S checkpoint. So with most lymphomas, it's going to be featured by painless lymphadenopathy, along with splenomegaly and bone marrow involvement. In this particular case, the mantle zone lymphoma, it can also involve the small bowel and form these lymphomatoid polyps. So there are these polyps made out of lymphoid tissues. The markers would be the CD1, CD19, CD20, CD5. So these are going to be a mix of both B and T cells, along with IgM and IgD, like high levels. So what's special about this is that it's CD5 positive but CD23 negative, which will distinguish it from the chronic lymphoid leukemia and the small lymphocyte leukemia. So there are no large cells, sort of similar to SLL, but it's still, since it's a non-Hodgkin lymphoma, there is not a great prognosis. So here is the mantle zone, and it's going to be, it's going to proliferate. So it's concentrating mostly on the naive B cell. So it is a indolent, rarely is it indolent, but it starts off indolent, and then it progresses into the classical form, which has like high karyotypes or complex karyotypes and high proliferation, but it can transform into the blastoid MCL. Follicular lymphoma is the most common type of lymphoma, and it affects both men and women equally. The neoplastic B cells will resemble the normal germinal center B cells, and it also presents with the generalized lymphadenopathy. The markers would be CD19, CD20, CD10, CD5. These are all B cell markers. And BCL2 in particular is going to be present in the follicular cells. So it starts off with in situ follicular neoplasm, and then it starts involving the other nodes around. The mantle zone is going to be dark and it's polarized. There's going to be a lot of macrophages containing the tingible bodies. And the small lymphoid cells are going to be like cleaved. The nuclei are going to be cleaved. And it destroys the white pulp in the spleen. So what's left is only red pulp. And all the follicles will be varying sizes. So the follicles would be not just in the spleen, but in the lymph nodes too. So this will involve the bone marrow. In particular, the pre-trabecular lymphoid aggregates will form, and the hepatic triads. So it's caused by the translocation between chromosomes 14 and 18, and that causes an overexpression of BCL2 in the germinal centers. So IgH will switch with BCL2, and then there is going to be a mutation of the MLL2 gene. So all of that makes the B cell able to avoid apoptosis due to the abnormal regulation of the gene expression. So in this cancer, there's an indolent waxing and waning course. Like they get better and then they get worse, and they get better and then they get worse. The unfortunate is that this can transform into diffuse B cell lymphoma, and by the time it does, it would be fatal. Okay, so what is diffuse large B cell lymphoma? This is the most common non-Hodgkins lymphoma, and it causes the dysregulation of BCL6 by the translocation of chromosomes 3, 14 to 18, and a MYC translocation. So MYC translocation involves chromosome 8. The markers would be your B cells, so that would be CD19, CD20. But this is particular for the diffuse large B cell lymphoma. It would be CD79A. The tumor cells would have round nuclei. They're like vesicular-like with the pale basophilic cytoplasm. And the cells are anaplastic with no B or T cell markers, but they have the clonal IgH gene rearrangements. So they either appear as large masses in the spleen, and they can be centroblastic, immunoblastic, polylobated, but it can also be unclassifiable. This is a fatal disease, and there are several subtypes associated with severe T cell immunodeficiency due to like HIV or just genetic immunodeficiency, and it's associated with the Epstein-Barr virus. So, Burkitt lymphoma, there are 3 subtypes. The endemic form, which is in Africa, and that involves the oropharynx, the kidneys, the ovaries, and the adrenal gland. The sporadic is non-endemic. It involves more of the ileocecum and the peritoneum. And the aggressive is associated with HIV. All 3 are associated with the Epstein-Barr virus, and the endemic and the sporadic types are more seen in children and young adults. So the Epstein-Barr virus will cause the translocations between chromosome 8 and 14, 8 and 22, and 2 and 8. So all of this involves the MYC gene. And because of the MYC gene involvement, there's a high mitotic index. However, this does respond quite well to high-dose chemo, so prognosis is pretty good. The markers would be your B cell markers, so CD19, CD20, CD10, along with a lot of surface IgM. There are kappa or lambda light chains present, and the tumors can involve the extranodal site, especially in the tissue, and those will show a diffuse infiltrate of intermediate-sized lymphoid cells. The characteristic histological slides would be a starry sky appearance, where the benign foamy macrophages are going to be scattered throughout the basophilic small lymphoblasts. The lymphoblasts will have like oval nuclei and coarse chromatin. Okay, so B cell neoplasms that secrete monoclonal immunoglobulins and excessive light chains, which are known as Bence-Jones proteins, those are the plasma cell neoplasms. And a different type, or the plasma cell cytomas, will make IgM, while multiple myeloma will produce more IgG. The Waldenstrom macroglobulinemia is going to cause a hyperviscous syndrome, and there is going to be high levels of IgM. It's more common in adults with the lymphoplasmacytic lymphoma. So the heavy chain disease is a rare monoclonal gammopathy where there's a problem in the synthesis and secretion of the free heavy chains. The primary or immunocyte associated amyloidosis is going to cause the excess secretion of the light chains. There's going to be benzone proteins in the urine. And the monoclonal gammopathy of undetermined significance, it's going to have no signs or symptoms, but there are elevated M components in the blood. This one is problematic because it can transform into the multiple myeloma. So in the plasma cell proliferation, the marrow cells are going to be replaced by plasma cells. And the proliferation of that clone is going to secrete and make the homogeneous immunoglobulins, or they're going to make like fragments of those immunoglobulins. The M component and the benzone proteins are going to be present in the blood, while the benzone protein is going to be excreted in the urine. So since the marrow cells are going to be replaced by the plasma cell, osteoclasts are going to be activated, and there is going to be bone pain and skeletal changes. So however, there is no hypercalcinemia in this plasma cell neoplasm. It's also known as POEM syndrome, which is going to be a combination of plasma cell proliferation disorder, polyneuropathy, and end organ problems. It's in older adults, so 50 to 60s, and it's much more common in men. Okay, so multiple myeloma is characterized by the masses throughout the skeletal system, and it can be solitary myeloma or smoldering myeloma. All the myelomas are going to excrete excess IgG. Remember, multiple myeloma, IgG, the plasma cell neoplasms, that's going to be IgM. The smoldering myeloma will have no symptoms, that's why it's smoldering, and they produce high plasma M components. This is chronic, progressive, and fatal. It's characterized by the neoplastic proliferation of those plasma cells that infiltrate the bone marrow, and in the late stages, it metastasizes to the lymph nodes. So the difference between the multiple myeloma and the just plain old plasma cell neoplasm is that this migrates, metastasizes to the lymph nodes. So in the bone marrow, IL-6 is going to be made by the neoplastic plasma cells and along with the normal stromal cells. So that's going to allow the proliferation and the survival of all the tumor cells. It's caused by the Ig heavy chain rearrangement on chromosome 14, and that's caused by the deletions of either 14q32 or 13q. It's also caused by the translocations of 14 to 11 or 6, and a rearrangement of chromosome 8. So you know that's going to be a problem with the c-Myc gene. It's also associated with the deletion of chromosome 17, and that causes the Ig heavy chain translocation with the cyclin D, either D1 or D3. And there's also a mutation of the NF-kappa B path, and all that causes the B cell survival and the evasion of apoptosis. So, multiple myeloma is more common in African American males, and the neoplastic plasma cells are going to secrete MIP1A and rankle, not just, the CD19, CD20. The bone marrow involvement is going to cause the destruction of the medullary and the cortical bone. So, this is one of the symptoms, or like mnemonics for the symptoms. So, CRAB for high calcium, renal problems, anemia, and bone problems. And that is like pathologic fractures, bone pain, calciuria, calcium stones, depression, anemia, and increased infections. So the myeloma cells will make the MIP1A, which upregulates the NF kappa B receptor to activate the osteoclast and release the modulators to inhibit the WNT path. So this is like a killing one bird or two birds with one stone. So it activates the osteoclast and it inhibits the apoptotic path. Okay, so what's happening with multiple myeloma? It's going to cause anemia, clearly. The destruction of the bone marrow is going to decrease the amount of blood made, thrombocytopenia. There's the destruction of the platelets, or the platelets are just used up. And all of that's going to lead to the increased viscosity of the blood. In the blood, there are the rouleau formation, the multinucleated cells, the flame cells, and the Mott cells that are going to be formed. And those are going to have a lot of like inclusions. So in the Mott cells, there's going to be the Russell bodies. And in the Duchesse bodies, that's going to be found more in the nucleus. So the proteinuria is going to occur as well with the Benzstone proteins, and the hour rod like crystals are going to be the precipitated immunoglobulin, also found in the cells. Right here too. And these little like dots, the granules, are the Schnapper-Schneid granules, which are also the precipitated immunoglobulins, which is just a different type. It's also characterized by these punched out osteal lesions in the bone. You can see on the x-ray. Let's go back a little. Here. These are like really, really distinctive for multiple myeloma. And then in a autopsy or in surgery, you can see there are soft gelatinous tumor masses on the bone. So these plasma cells are pretty bad. They can infiltrate the organs, the bones, and produce even more immunoglobulins, causing more problems. So renal failure is going to occur due to the deposition of the toxic Benzstone proteins to the renal tubular cell, and there is the metastatic calcification, there's the destruction of the bone. So there's going to be recurrent infections of S. pneumonia, S. aureus, and E. coli. There are different types of anemia that occurs. So the normocytic, normochromic anemia, along with moderate leukopenia and thrombocytopenia. All this is the translocations between 4 and 14, deletion of 17p, and these will have the worst prognosis. But all in all of them have pretty poor prognosis in general. This is just going to cause a much more aggressive form. So lymphoplasmacytic lymphoma is going to affect the elderly patients, and it's when a B cell neoplasm differentiate into plasma cells. And the malignant lymphoplasmacytoid cells are going to make just IgM. So in multiple myeloma, it was IgG. In lymphoplasmacytic lymphoma, it's going to be IgM. So it manifests as hyperviscosity monoclonal IgM syndrome. So that will lead to the Waldenstrom macroglobulinemia along with heavy chain disease. So here's another comparison versus multiple myeloma once again. Unlike multiple myeloma, the heavy and light chain synthesis is balanced, while in multiple myeloma, there is only heavy chain made. There's no complications from the secretion of the light chains. The tumor will disseminate just to the lymph node, the spleen, and the liver. Multiple myeloma, it just goes everywhere. More importantly, there are no lesions. There's no punched out seen on the x-rays. However, this will cause central nervous system symptoms. So they will have infiltration to the nerve roots and the meninges. Multiple myeloma will have hypercalcinemia, and this will not, but rouleau is seen in both multiple myeloma and this particular disease. So the central nervous system involvement will have the the visual disturbances, along with the weaknesses, but there's also really generalized features such as weight loss, hemostatic disturbances, lymphadenopathy, and organomegaly. The hyperviscosity syndrome is going to cause the neurological problems, the bleeding, the Raynaud's phenomenon, and in a blood test, here's the rouleau formation, and there's a mix of small lymphoid cells which have various degrees of plasma cell differentiation, but they're all turning into plasma cells. The periodic acid shift stain is going to show the Russell body and Duchenne bodies, and the marker is a B cell marker, CD20. So Hodgkin's lymphoma is a neoplasm of the lymphoid tissue, and the spread is going to be methodical and is usually localized to a group of nodes. It's going to be characterized by these Reed-Sternberg cells, also known as the owl cells, because of those two big nuclei. And the origin of these cells are going to be either the germinal center or post-germinal center B cells. The NF-kappa B path is going to be activated by either the Epstein-Barr virus or by spontaneous mutation. The Epstein-Barr virus will infect the cells that express, and they will cause the cells to express LMP1, and that's found in the lymph nodes of patients with mono. So in mono, that's going to affect mostly young adults. So the Reed-Sternberg cells have a bunch of variants, and those can be distinctive for certain lymphomas. The Reed-Sternberg cells are going to be aneuploid. They have a bunch of chromosomal aberrations, and they release the factors that induce the accumulation of reactive white blood cells. The mononuclear variant is going to be, let me find it right here, and it's going to have a single nucleus with a large inclusion body like nucleolus. The lacunar variant is going to be found in the nodular subtype of Hodgkin's lymphoma, and those will have folded multilobate nuclei, and it sits in a nice little lake. That's why it's called lacunar. The classic Reed-Sternberg cell will have these pynotic, not shapes, but inclusions in it. It's going to be the degraded parts of DNA. So those are going to be mummified cells, and the lymphohistiocytic variant is going to have a polyploid nuclei, inconspicuous nucleoli, and an abundant cytoplasm. Here's the mononuclear version. Here's the mummified Sternberg cell. Here's the floret or the lymphohistiocytic variant. Okay, so nodular sclerosis is the most common form of Hodgkin's lymphoma. They have the lacunar variant Reed-Sternberg cell. It's characterized by these very well-defined bands of collagen, and those will divide the tumor cells and the infiltrates into nodules. And they have the very particular moth-eaten or mottled cell appearance due to the cluster of the lacunar cells and the microabscesses or necrosis. The markers would be PAX5, CD15, and CD30. and they generally involve the cervical, the supraclavicular, and the mediastinal lymph nodes. Luckily enough, since it's a Hodgkin's lymphoma, there is pretty good prognosis. The mixed cellularity is a classic Reed-Sternberg cell, and it affects older males. The Reed-Sternberg cells are going to be binucleated, and it's surrounded by a bunch of reactive cells. Those cells will be generally infected by the Epstein-Barr virus, and there's going to be a destruction of the nodal architectures, but no sclerosis. So as you can see here, it's getting undifferentiated, and there is no bands of collagen. And even here, there is no differentiation between like the follicular, the paracortical, the cortex, and the margins of the lymph node itself. So the symptoms are nonspecific, but it does have a pretty good prognosis. The lymphocyte-rich version is going to have reactive lymphocytes along with a mononuclear variant of the Reed-Sternberg cells infected with Epstein-Barr virus. So once again, nonspecific symptoms, good prognosis. The lymphocyte depletion is going to be the rarest form of Hodgkin's lymphoma, and there's going to be many variants of the Reed-Sternberg cells, and those are going to be infected with either the Epstein-Barr virus or HIV. The lymphocyte predominant form is going to be filled with these popcorn variant, lymphocytic or histiocytic variants of the Reed-Sternberg cells. It's pretty rare too. It's characterized by these nodular infiltrates of the small lymphocytes mixed with macrophages, and this generally affects young males. The markers would be CD20 and BCL6. It can transform into a tumor resembling large B-cell lymphoma, but unlike large B-cell lymphoma, it has a pretty good prognosis. So the frequent presence of the Epstein-Barr virus in the Reed-Sternberg cells will increase the chances of transformation into something more malignant. And the markers we've got to look out for during the transformation is CD15 and CD30. So that means that there's going to start involving other cells. So this will usually affect the lower cervical, the supraclavicular, axilla, and mediastinal lymph nodes. So like all the lymph nodes in the trunk. The lymph nodes are going to be painless, and they're going to be filled with eosinophils. And the patients are going to have this Pell-Epstein fever, where the fever is going to like wax and wane over like 1 or 2 weeks. And this is pretty common in Hodgkin's lymphoma. So like I said, Hodgkin's lymphoma is pretty good. We usually treat with surgery, but we can also give rituximab, a monoclonal antibody, along with chemo. Okay, back to non-Hodgkin's lymphoma. In general, it's just a group of blood cancers that includes all types of lymphomas, and it's hard to treat. Like I said, the causes can be varied and hard to treat because chemo can cause the tumor lysis syndrome, and the infected or the cancer lymphoma cells will release its contents in the blood and overwhelm the kidneys and lead to kidney failure. So the problem is it's really hard to differentiate non-Hodgkin's from Hodgkin's lymphoma based on symptoms alone, because the patients will present with similar non-specific symptoms. So the marginal zone lymphoma is going to involve the lymph nodes along with the MALT and the spleen. So this is going to affect like GI tract. The extranodal versions will involve the areas involved with chronic inflammation and by autoimmune disease or infection. So that's in general like mucosa. The markers would be CD19 and CD20, so this is a B cell thing. The somatic hypermutation of the memory B cell is going to occur, and it's going to start as a polyclonal immune reaction. So problematic. So once the B cell is precursor is infected, this tumor can spread via all avenues of the B cells, right? It can transform or it can differentiate into all these other different cells, not just like a monoclonal spread. It's caused by this translocation upregulation, and a translocation, and it will upregulate the function and the expression of BCL10 or MALT1 to activate the NF-kappa B path. Luckily enough, this can regress if the inciting agent is removed, and it stays localized for a long time. So the presence of leukocytes in the lymph node is good. That means, the body is recognizing that something's wrong. And the presence of the T regulatory cells is a bad sign. So the hairy cell leukemia is pretty rare. It has an indolent course, and it's more common in middle-aged males, or we catch it more in middle-aged male. The cancer markers would be CD11C, CD25, and CD103, along with annexin A1. It can infiltrate the bone, the spleen, and the liver, and it responds very well to interferon alpha. The cells are going to have these little not inclusions, but projections, and those will make it appear hairy. The bone marrow is going to be hypoplastic, filled with fat cells. It's going to be fibrotic, and sometimes it presents with pancytopenia. And there's going to be collagen infiltrate of the bone, and the infiltration of the splenic pulp is going to cause the destruction of the white pulp. So here's the white pulp, here's the splenic cores, and this is the spleen, but there is no white pulp at all. It's all disseminated like red pulp. What's particular about hairy cell leukemia is that there are unexplained monocytopenia. So that is strange, but a pretty significant characteristic. In these patients, there is increased atypical mycobacterial infections. Okay, so mycosis fungoides is going to be skin tumors of the CD4 cells, and they present as these lesions, and it looks sort of like fungal rings. That's why they thought it was a fungus, but it's not. It's a cancer. It's an indolent disease, and the markers would be CD2, CD3, CD4. These are all of the T cells. The mycosis fungoides will have phases, so it's pre-mycotic, and then it forms a plaque, and then it forms a tumor. And the infiltration of the epidermis and upper dermis of the neoplastic T cells, and it can spread to the lymph nodes in the bone marrow. The Causary syndrome is another form of the mycosis fungoides, and it's a cutaneous T-cell lymphoma, but the tumor is going to disseminate to the other organs, so it's not just limited to the skin. It will manifest itself as a generalized exfoliative erythroderma, so there's all over the skin. There's no tumor phase, so it goes straight into the blood, and the Causary cells are going to be characterized by these cerebroform nuclei. So it looks sort of like a cerebellum, but they're also known as the buttock cells, which I like to think of because it sounds kind of funny for a not very funny disease. The markers would be CLA, CCR4, CCR10, and it's an indolent disease, but once it transforms, it is fatal. Okay, so that's it for now. Thank you for your attention, and good luck studying.